So the top line results, after we completed, we reached a milestone, which is the 10-year median follow-up. And our primary endpoint was disease-specific mortality from prostate cancer. And the news was good. So the first thing to say is that if a man is diagnosed with prostate cancer by PSA and has clinically localized disease, his chances of dying of prostate cancer are very low. The risk is very low, and it's around 1% irrespective of the treatment that's been allocated to him, whether it's active monitoring, surgery or radiotherapy. And that's really good news because it gives time for the patient to consider all the treatment options. The second piece of good news is that treatment works. So although there's a lot of overtreatment, when treatment is necessary, it does reduce the incidence of metastasis and disease progression by approximately half. And this is helpful because for the first time we're able to show that if patients need the treatment is going to help them. The third point is for the first time surgery and radiotherapy were compared head to head. This had not happened before, and we've shown again that the two are pretty much equivalent in producing the same effect on the cancers that need to be treated, and there's not much to choose between them. The final thing is that we looked very carefully not just at oncological outcomes but at patient-reported outcomes, so how patients feel about having received the surgery, having received the radiotherapy, receiving active monitoring. They reported these outcomes through very thorough questionnaires, and all these were analyzed. What we found was that the impact of surgery is mostly on continence, urinary continence and erectile function. Some of it recovers over time, but doesn't quite go back to baseline. For radiotherapy, it has more effect on the bowel motions and bowel habits, and some of that also recovers. And interestingly, for men who are on active monitoring, with aging and changing management, they also get symptoms, so they're not free just because they're not receiving treatment. They're not free from the symptoms which come with aging. And what this has allowed us to do, to have the patient perspective, is to allow for a trade-off to be worked out by the patient himself when he knows he has these treatment choices. And the trade-off is between what is the benefit oncologically of having the treatments, but what is the price that we pay in terms of side effects. And this allows patients to be better informed when they come to making their choices.